Hello, everyone. Welcome to today's webinar. It's a continuation of our webinar on lipedema identification and intervention. And we're very happy to welcome back Lindsay Ryback, who is the Senior Product Manager of Compression of LNR USA. And also Deana Benjamin, who of course is our main speaker, and we look forward to hearing more from her as well. And so I'd like to welcome Lindsay, and she's actually going to be managing the questions today. But Lindsay, welcome.
Yep, welcome. Hello, everybody. Good evening. Thank you guys for being here today. I'll be managing the Q&A section. So unlike part one, we won't be using the raise hand function because we want to make sure we can get through everybody's questions that they submit. So please make sure to type those into the Q&A box and not the chat box so that we can make sure we see your questions as they come in. And I did just see one that I'll answer right away. Since I missed part one of the lymphedema program, will I be able to view it at a different time? Yes, both sessions will be recorded, so you guys will be able to watch those. So keep an eye out for your email to be able to find a link to the recordings available.
Indeed. The first one is already up on our website, the NLN website, under sponsors, LNR USA. So if you missed it, you can catch it there. And we would like to take a moment to thank LNR USA for being a significant sponsor. They are a Magenta sponsor. And what that means is that they significantly support us. And therefore, we're so happy to have you here. And we'd like to welcome Deana Benjamin to the stage. So whenever you're ready, Deana, you can come on, and we look forward to hearing more about what you had to say about lipedema. So thanks for being with us.
Great. Thank you, Jeanette, and thank you, Lindsay. And welcome, everyone. I'm pleased to see the participation level here is very high. I hope you were all able to join on Tuesday. But if not, that's okay. This presentation will kind of stand alone. So you could view the part one at a later time, which will be totally good. Today's topic is intervention. So I'm really excited about this because as therapists, this is the part we love to do, right? We love to get in and treat our patients. And I'm happy to share the techniques that I've learned treating lipedema over the past 15 plus years, and hopefully help some therapists learn some new techniques. I am a clinical manager here at Christa St. Vincent Sports Medicine in Santa Fe. We have a very large clinic. I now have 3 CLTs working here and another one that's training. And I'm also the founder and president of Everything Lymphedema and Lipedema, New Mexico. And I'm just excited to share all of this with you guys tonight. So our learning objectives for today will be treatment options, basically. So talking a lot about manual lymphatic drainage as well as deep techniques. We're going to go through a few modalities, talk about the advanced vasopneumatic pumps, a little bit about the basic pumps also, some compression options, and then just kind of touch on exercise and skincare and education, as we know those are all important of complete decongestive therapy. And I will just mention a little bit about surgical intervention and also nutrition. So just a little bit of a recap from Tuesday, just to kind of start out with a little bit of a base on what lipedema is. So we know it's a disease of the fibrotic loose connective tissue, that it affects the limbs and the lower trunk, but spares the hands and feet and head and neck. And it results in a lot of pain from the fibrosis that's resultant of the inflammation in the tissue. We also know it's very under-recognized, mostly because it is common only in female, and it's often assumed to be a usual part of their hereditary fat instead of a medical condition. And then that other key point from Tuesday was that lipedema can be treated to reduce the pain and edema. And we also want to maintain mobility and improve quality of life while also slowing that disease progression. So we really want to get an early diagnosis. We want to spread awareness as much as possible, not only to our colleagues, our therapists and massage therapists and PTs and OTs, but also to providers and patients themselves. So again, just to review, because I may mention this throughout the talk, so the different types, so we're all on the same page. Over the years, there has been a little fluctuation in typing. So we're going to go, type 1 is the hips and buttocks, type 2 extends down to the knee, type 3 all the way down to the ankles, type 4 includes the arms and can be combined with type 1, 2, 3, or 5. and type 5 is only the caps. So those are our typings. And then the stages. That first picture on the left is a quote unquote normal or average lower extremities. Then we have a stage 1, a stage 2, and a stage 3. Progressing from kind of that smooth skin, that smooth texture, to more nodules, more lipomas, more pain, and then some asymmetries, lobules, more edema, and involvement of the feet can happen once we're including a component of lymphedema. So those are our stages. Okay, so just very briefly, for right now, currently, the treatments that we know of are CDT, which is what I'm going to talk about tonight. We also hear a lot about surgical intervention. This is generally liposuction. There are many techniques to performing liposuction. I'm certainly not an expert on this. I've had a few patients who've had it done. But what I do know is that you really have to be experienced. You need to go to an experienced surgeon because of the intricacies of that lymphatic system. As therapists, you know, if we know the anatomy, we know what those little pre-collectors look like and those initial lymph vessels and where those lie in the tissue and how numerous they are and how fragile they are. So you really want to go to a surgeon who has a lot of experience in sparing those vessels so we don't cause more damage to the lymphatic system. With most of those surgical interventions, you're going to have extensive bruising, just part of the process. You're going to have entry sites where the instruments went in. Those often have some scar tissue and pain and myofascial adhesions. So that's something that we will work with. Most patients need custom compression for whatever body part the surgery was done on. And that's recommended to wear 24/7 in every case that I've seen. And that's for several weeks or months even. So taking it off only to shower. And then in most cases, they're still recommending the CDT. So they still want the manual lymphatic drainage. They do want the compression. So it's still an important part of the care. So that's what we'll focus on tonight. And then medication. There's still no specific medication that can relieve the symptoms specifically of lipedema or cure lipedema. There is some studies out now about metformin maybe being helpful. Generally, diuretics are not recommended. They kick off the fluid, but you know, there's a lot of protein in lymphedema and in lipedema that's just going to hang on to that water because it's hydrophilic. So usually the diuretics are not recommended. And there are a whole lot of supplements that are recommended. I'll get into that a little bit later in the talk. So let's get into the bones of what we do as therapists. Manual lymphatic drainage is one of the main parts of complete decongestive therapy. What we want to do with manual lymphatic drainage initially is really to reduce pain and tenderness with our patients that have lipedema. A lot of them are very sensitive to the touch. They certainly can't handle any deep techniques. Just the manual lymphatic drainage itself can be quite painful. This is because of that buildup, a lot of it lactic acid and other toxins that have just kind of built up in the skin or in the tissues. With that manual lymphatic drainage, the first few sessions, most of our patients experience fatigue following the session. I always say if you could take a nap, your body would really like you to shut down so it can process all of these toxins and fluids that we're processing through the body now. I also hear a lot about nausea or GI upset after the first few MLD sessions for that same reason. And then a lot of patients will mention too a change in the odor of their urine or perspiration. So I always kind of mention these to my patients so they know what to expect following a session. And actually I usually mention them at evaluation time so that they can prepare for their first full session. And sometimes we don't do a whole hour the first session with a lipedema patient. You really have to gauge it on what they're experiencing and what they can tolerate. So along with reducing that pain, of course, we want to reduce edema. All lipedema patients have a component of edema that has started. There's that microvascular damage and there's the lymphatic damage. As they progress through those stages, the edema becomes a larger and larger component. So we certainly want to work on reducing the edema present. The manual lymphatic drainage does stimulate that parasympathetic nervous system. And I usually share that with my patients too and help them understand that when they're, under a lot of stress, that their lymphatics are not working as well. So if they can really take time in their day to relax, that's going to help them as well. I do recommend a CLT especially for lipedema treatment, just based on the level of training and experience you're going to get with a CLT. But the other thing I tell my patients is, if you see someone and it's working and it's helping, then that's great. If you're going to treatment and not seeing any improvement, then I would try a new therapist. So, with lipedema, the treatment really needs to be consistent. It does with lymphedema as well. But with lipedema, this is a much slower reduction process. The reduction happens over time, even years. And we can start to see changes with pain reduction and edema reduction pretty quickly. But the fibrosis, all those adhesions, it just takes a long time. So it's good for the patients to know that this is not a quick fix. You're going to have to be committed and consistent and compliant. I do find with lipedema, we generally need to do a more aggressive skin stretch. This is still, of course, a horizontal or lateral skin tug. There's no downward pressure into the tissue with the MLD, but you do want to get that full skin stretch. Okay, so I'm going to show a video of me performing MLD on a patient's thighs with lipedema. I'm going to admit that I think it's a little bit fast compared to how we should perform the MLD in the clinic. And it's also maybe a little deceiving at first. It almost looks like I am pushing down into the skin. But we want to be careful there with that lateral tug. Okay. And I was certified through the Academy of Lymphatic Studies. So we were trained in the deep techniques, that thumb push that I'm showing you and the S-wave. Some other therapists I've met from other centers were not trained in those techniques, but they're very simple and easy to use and can be very helpful. With our deep techniques, we want to realize in lipedema that deep techniques are important. You have to have the combination of the manual lymphatic drainage to move the fluid and the toxins, but also those deep techniques to break up the fibrosis around all those adipose cells, as well as through the fascia that happen over time. They do not damage the lymphatic system. We are trained in those, and there's a lot more research out there now to support doing these deep techniques with lipedema patients. We do want to begin these techniques later in treatment when the patient can tolerate them. When you first get a patient, they're going to be, generally pretty tender, and you don't want to overwhelm, the system, first of all, or the patient. So I do just soft tissue mobilization with prolonged pressure, even some trigger point release. I do the thumb push and the S-wave, and I'll show you guys those techniques again in a few minutes here. We do a lot of myofascial release in the clinic. Skin rolling can be really helpful. And most of us here are trained in the anatomy trains, the Thomas Meyer, and that's a whole specialized course that you learn how to basically take the slack out of the fascia, and then the patient does active motion with that slack reduced to really stretch the fascia in whatever plane or train is tight. So that can be really helpful. Excuse me. We also do use iStim tools. That's instrument-assisted soft tissue mobilization. I am certified in the hot grips technique, and we use those tools here in the clinic. I will show you those as well. And then also cupping. We do cupping. You can do cupping for the manual lymphatic drainage itself, and then you really want to go in the same direction and order as you would with manual lymphatic drainage techniques. But we also do it for pain and fascial release as well. So I'm going to show you guys some videos of those too. So this
Mhm,
one here is
real
some deep
quick.
techniques on the arm.
And real quick to ask a couple questions to your last video, someone had posted, do you move the fluid laterally and upward towards the axilla versus directly to the inguinal lymph nodes?
Yes, we usually do. We still do the rerouting where we work. We actually usually work our cervical, supraclavicular, and axillary lymph nodes and do our deep breathing, and then the inguinal nodes. So we reroute just as we would with a bilateral lower extremity lymphedema. But we also work those inguinal nodes too. So I think, there can be some drainage through both areas, but generally that upper trunk region is not affected. And unless they have severe lipedema in the upper extremities, maybe with some lymphedema, then we might hesitate overwhelming the axillary lymph nodes. But in general, yes, we do the rerouting as well. Great question.
And then what stage would you consider that patient to be?
She's probably a stage 2 to 3 at this point. There's quite a bit of swelling. Their feet really aren't affected, but there's a lot of fluid. Her calves are very full. Yes.
And then you mentioned it is more of a lateral motion than downward, correct? What is the
Correct.
reason behind this?
Well, we don't want to, for lack of a better word, smash the initial lymph vessels that are right up in the surface of the skin. We really want to tug them open. They have these little anchoring filaments, and you want to pull them open as you do the drainage, and then they filter that fluid down to the other vessels and off to the lymph nodes, to be very basic about it.
Thank you.
Yes, you're welcome. All right, so here is a video showing some of those techniques that I've learned with the Academy of Lymphatic Studies. All right, this is iStim. Okay, so you can see the involvement in the calf there, that's pretty severe lipedema. And she does have a lot of nodules, a lot of pain, a lot of adhesions throughout both lower extremities. So the iStim, this was a little further into treatment, and she was able to tolerate these techniques pretty well. All right, and I'm going to show you some cupping here. And, I mentioned with manual lymphatic drainage, you'd want to do your cupping, starting proximally, but really working up towards the regional lymph nodes. But for myofascial release, you may need to do it in opposite directions. So you'll see me go both proximally and distally here with the cupping. But at the end, instinctively, I do a stroke of manual lymphatic drainage to just kind of push up. And it's important to know that all of these deep techniques are done usually mid-session, so that there's a lot of opening up the lymphatic system prior to doing any deep techniques, and then a lot of flushing afterwards to also pick up any toxins that we created, any of that fibrosis that was broken up. All right, so here's the cupping. All right. So there are some other modalities that we use in our clinic a lot, and I've seen good results with. One of them is ultrasound. We do this on a fibrolytic setting. This is also something I learned through the Academy of Lymphatic Studies. This is a low intensity, a 0.2 watts per centimeter squared. And we do it on that pulsed setting, that non-thermal, because we don't want to have a lot of heat that might increase edema in the area. But if you have a small, stubborn area that's really bothering the patient, this can be a good modality to pull out of your toolbox. We do a lot of kinesiotaping also. One of my CLTs is a certified in kinesiotape. I am not, but I do use a lot of the techniques and have kind of, worked to find some that work well for certain things too, that weren't really taught in the certification courses or in the book. And I'm going to show you all of those too. And then we also do McConnell taping a lot if they do have that lateral tracking patella that comes with the patellofemoral syndrome or the genu valgum, that knocked knee situation. So, we do use that if we need to, just to acutely reduce that pain. It's not something I want to do long term. I really want to work on the strengthening of the VMO and the glute medius and stretching of the IT band. But initially, it can really help reset the patella on the femoral condyles and provide some pain relief. So that can be really helpful. So the kinesiotape here, I'm going to show you actually all of those that I have listed. So this is kinesiotape to lift lobes. I have seen really great results with this. That lobe generally would hang down to the very edge of her foot. And we went through a series of taping up the lobe and then covering with short stretch bandages. And it really helps that skin tighten up and decreases the severity of the lobe. You do want to make sure that your patients have really good skin integrity for this type of technique. We are applying a lot of tension to the distal end of it here, and then just placing the tape down on the upper half. Here is another picture of lifting lobes. And this patient had so much knee pain when she first started. And you can imagine with all that weight pulling off to the side of the thigh, how difficult that would be. So we use this tape to lift the lobe and redistribute that weight a little more medially, a little more over top of the knee. And it's a little hard to tell here, but you can see here, I mean, I didn't have her move. I taped her and took another picture, but you can see her kind of hanging over the edge. And here you can just see that this is, that her thigh is lifted quite a bit with that tape. So that can be really helpful. Again, that's not something that I want to do long term. We really want to reduce the size of that edema, but can be really helpful acutely to help reduce that pain. Again, you need to be careful about skin integrity though, because there is a lot of tension again on those distal ends of that tape. Kinesiotape fan for edema. This is a technique I use a lot. Often I also cross hatch them so they're actually crisscrossing each other, which is really helpful. We're headed the anchors up at the medial knee in this to really support the flow of the anatomy of the lymphatic system. And the kinesiotape here really just puts a micro stretch on the skin in those pathways. So I tell patients it's almost like me walking around with my hands on your skin, opening your pre-collectors. The great thing about kinesiotape, it's not bulky, it's non-invasive, inexpensive, comfortable, and it's a micro effect, but you can wear it for 3 to 4 days as long as it stays in place. So it's really kind of a miracle, really, for how simple it seems. This one is a witch's hat. So you want to make sure an incision is really healed well before you would use this, but you could use it on any incision or an area of scar tissue. We actually use this sometimes on our breast cancer patients also who had a mastectomy or just have an area like maybe a drain site that's really stuck. But we kind of make a cross here and make a little tab. And then you just, with no tension, put the square, the rectangle over it. And then it's a little pull tab for the patients to actually self-mobilize their own scar tissue. A patient can tell where it's really tight or really hurts more. And this way, between therapy sessions, they can keep that benefit of releasing some of those myofascial adhesions and helping with pain. Okay, so kind of switching now from those modalities into vasopneumatic pumps. I'm not going to talk a lot about this, but they can be really helpful tools, especially in lipedema, where the progress is going to be so much slower and take years really to make big changes. An advanced or a basic pump can really help the patient be independent at home and keep up with all of their self-care. So basic pumps are the ones that are easily covered. Generally, these are contraindicated for people with lymphedema, and in my opinion, lipedema as well. They do start distally, and so the easy analogy is, they take all the swelling in the foot and pump it up to the calf, and then they take all of that and pump it into the knee area, and then all of that and pump it into the thigh. So by the time you've gotten up to the thigh, it's a lot of pressure on the lymphatic system and can mechanically damage those vessels. So you have to be really careful who you use a basic pump with and make sure they're not having pain, make sure that it's not exasperating their symptoms or causing truncal edema, because it does not cover the trunk either. They're usually pretty simple, 4 to 8 chambers. There's several out there in the market. But this is the one insurance will usually cover. So if it is helpful for the patient, it could be a benefit. So I'm obviously more a fan of the advanced pumps, which do cover the trunk, and they start proximally, just like we do in MLD. They have a lot more chambers, some have 30 to 40 chambers. They're more comfortable. It takes a smaller amount of skin and provides that skin stretch to stimulate the lymphatic system. This can be helpful for decreasing pain for patients with lipedema, as well as improving their lymphatic flow and reduce the risk of infection. I don't see infection as much in lipedema patients, certainly, unless they have that element of lymphedema. But they have a lot of good research out there for them and are known to reduce the risk of infection too. So there's basically 2 advanced pumps out there that are recommended in our lymphedema world. And I'm sure everyone knows FlexiTouch with Tactile Medical, and there's also LymphaPress. Okay, so no big questions about that so far. Let's move on to the compression phase of this. So compression is the part no patient usually really loves when they first start. I don't know that I've ever had a patient that says, I can't wait to wear compression socks and have my legs wrapped. The massage part, the manual lymphatic drainage, of course, that part's a lot more enjoyable and relaxing and can see the benefits. But generally, once a patient starts wearing their compression, they see the benefit. I have patients say they feel more energized when they're wearing their compression. It just gives them more endurance. They overall feel better. So, you kind of have to work into it. Now with lipedema, you really have to start slowly as they can tolerate. If you try to put someone initially in a class 1 or class 2 pantyhose, they're probably not going to be compliant. They're going to have pain getting it on. They're going to have pain wearing it. So you really want to start slow. I start sometimes with the 10 to 20 or 15 to 20, and then slowly over time, see if I can get them in a class 1. Foot coverage, open toe is usually fine for lipedema patients. You don't want to put them in a legging that's going to expose that distal part of the ankle or the calf. You really want to make sure that part is covered. But generally, you can have a lower containment on the foot or on the feet for lipedema patients. So some of the liners that are out there now that have compression on the feet and then nothing in the calf can be helpful with certain types of garments. This is different than in lymphedema, systemic issues or chronic venous insufficiency, where you really want to have that distal compression be the greatest, really. But you do want to have some coverage, usually on the foot, or we could lead to some foot edema. Short stretch wraps. We do use these in our clinic for lipedema patients, especially if there's that lymphedema component now added on. We use a lot of foam. We use the Comprex, the dense orange foam. We make our own chipped bags with varying densities of that foam and varying shapes, irregular shapes, all mixed up from soft foam, medium density to that Comprex real dense foam, which we do call gold around the clinic here. It is a gold color. But we put those in areas of, higher fibrosis or pain. We also do use the Comprex kidneys. So I'll show those in a little bit here too. And swell spots can also be really helpful. So here's kind of just prepping a lower extremity that I'm about to wrap. So that's that Comprex foam there. I do bevel the edges of it so it doesn't make any indentations or cause any skin breakdown. And then we kind of pad that in there and do make the leg a little more columnar. Now this patient is starting to get some swelling into those first 2 toes. So we are wrapping there with a Translast. Here's a picture of those kidneys, and I will show that again here in a video. There's a couple sizes of them. They have a really nice beveled edge as well. And then I just wanted to show the Rosidol Soft. This is something that I found is really helpful, just to put one circumference of it around like the top of the thigh if you have trouble with the wraps slipping. There's a nice grip to it, a nice friction that kind of helps things from sliding. So I use it more for that than I do for padding. I tend to use the Salona for padding. Here's a couple of swell spots. The one on the left can be used kind of like a kidney. Let's say the complex kidneys are just too aggressive for someone who's really tender, but you want to get that extra compression in there, that extra pressure. The swell spots can be a good alternative. The one on the right is probably most often used for breast patients, but this can also be helpful on some of the lobes and the lower extremities as they become more severe. Okay, so I'm going to show you a picture of wrapping. This is me wrapping a patient with lipedema. And let's go ahead and start that. I could have cut that a little longer. So, not unlike wrap for lymphedema patients, the really only exception might be that I'm not wrapping the toes. I, of course, warn my patients if your toes would start to swell, take this all off and tell me next time. But generally, I don't see having a problem with it, especially with a little bit of layering on the foot.
A couple questions here. Yes. Do you have patients ever complain of foot pain when you don't use foam to make the foot more cylindrical? How do you avoid that?
So you're saying when I don't use foam to make it more column-like in the ankle portion? I think that's what the question is.
To make the foot more cylindrical?
The foot more cylindrical. I never use foam on the foot at all. We use the dense foam around the ankles, of course, and some Solona to pad the front of the ankle. But no, I don't have patients complaining of foot pain. We usually just have the stockinette on there and the short stretch bandage. If they did have pinpoint pain, I could add some foam in there just to pad that, or some Solona, probably not foam, probably more the Solona. But no, I have not experienced that.
Okay. And why are you not using padding on the whole leg?
Well, I have found that you don't have to, is the biggest thing. So I use far less padding than we're trained to do. And I think you're trained to use so much to really make a perfect column to make you a safe wrapper. So because of the pressures and because of that, the Laplace's law and the pressure being perfect, if you do it that way, we're trained that way so that we're all safe and providing consistent pressures as we go up, right? I think when you've wrapped for almost 20 years, you can kind of learn where you can take some shortcuts and you're gonna have a great gradient. You're still gonna start with the lower sized bandages. You're gonna start closer together, and if anything, widen your gaps. Certainly try to equal it out a little bit. But yeah, I guess that's why I don't, because I find you don't have to. And it helps patients be compliant if their leg is not so huge and not as hot. But, it's not something I would recommend out there unless you have a lot of experience wrapping and have shown that you are getting just as good of results with using less.
Awesome. And do you normally see them every day for bandaging?
No, we don't really do that either, especially not with lipedema. Lymphedema you can reduce a lot quicker. We might increase the frequency in lymphedema if we're using like a reduction kit, or not even with bandaging usually, though. The most we'd see is 3 times a week. With lipedema, twice a week is the most I usually see any patient, just because of that tolerance level and they need to process. So we will teach patients to self-wrap, or wear a lighter, easier type of compression in between sessions if needed.
Okay, and to go with that, someone else wrote, that looks like very aggressive bandaging wrapping. Are your patients able to tolerate that?
Yes, absolutely. So most of my, patients tell me a lot like, oh, I've never had wraps that stayed on before you. I've never had wraps that worked this good. So yeah, absolutely. I'm taking out, probably closer to that 60% of the stretch. But yes, absolutely. I mean, if they couldn't tolerate it, they wouldn't work. So if a patient does have a tolerance issue, we'd back up a little bit, but I don't see that. Good question.
Awesome. There is a flood of questions, but I want to make sure you can still get through the content. We will make sure we answer things at the end. So make sure to stay on at the end for the Q&A section. But I think we're going to have to jump back into the presentation. Thank you guys for getting those. Keep the questions coming.
Excellent. Great. Thank you. So I want to just mention too that I think, a lot of what I feel like I have to offer in treating lipedema is non-traditional. We weren't really trained to get in there and do iStim and cupping and all of that stuff. And when I first started treating many, many years ago with my mentor, I, to be honest, kind of started experimenting. And then I had some patients go see Dr. Herbst, and I got written and verbal, encouragement to continue with these things because they were really helping. And, over the years, talking to other therapists, and, I really look up to Dr. Herbst and what she's done for the lipedema community. She was able to come speak at the last conference that my nonprofit held here in Santa Fe. And just to continue to get that feedback from her, that it is important, that this is what we need to do. So I really stepped away from my mentor, who was a little shied away from some of these non-traditional techniques because they weren't taught when she was certified. So we need a lot more research out there, but that's kind of why I wanted to do this today, is to share some of these less traditional treatment options. So, okay, so compression in the phase 2 portion. I'm going to kind of show you most of these. I like going a lot of times with capris or shorts mixed with a knee high. You can always do open toe with lipedema generally, unless they've progressed. Exo soft is really nice, especially when they start. It's very comfortable, but you can progress to stronger compressions or compress to a little more containment with that Exo strong. I do like using Velcro wraps. They're easier for patients to put on. The Ready Wrap from L&R is a really good shape. It's a little more columnar than some of the other wraps out there on the market. And with the kit, this also comes with that fusion liner, which will provide a little compression to the feet. Pantyhose and leggings are great when a patient gets to that point where they can tolerate them and put them on and are going to wear them. And then nighttime garments, especially when there's that lymphedema component or it's really progressed and there is just a lot of congestion. I think the foam is really important because we know these adipose cells have a, like Dr. Herb says, they're locked in a jail cell of fibrosis, but really each cell has that fibrotic tissue. So that dense foam can be really helpful. There's the Tribute Wrap and also the custom Tribute Nights. So let's look at some pictures of those. This is a patient with the type 2, severe stage 3 lipedema. So here you're not going to be able to find an off-the-shelf pantyhose or legging that's going to work. So we have a combination here of some capris with knee highs. You'll see it is a little loose around her knee because of that, significant quick drop off. So making sure those knee highs can go up far enough to cover and contain that area. This is one of my post-surgical patients. She's got bilateral upper extremity and lower extremity. So she's that classic type 3 with the type 4. And she has the dual upper extremity coverage. And then this, the leggings that go all the way up to cover that distal trunk. And then if you'll notice on the foot portion, it is open toe, but definitely covering that ankle part that's needed. This is a Ready Wrap on a lipedema patient. Now we do have the liner under there. And then I just wanted to show you the extension. And with that extender strap, you're going to have a longer piece now. So you want to make sure the pressures match. The shorter the fabric, generally the higher containment you're going to have with that shorter stretch. So just being aware of that if you add that expander extension piece. Okay, these are pictures of the Tribute Wrap. Now we did leave the liner on in these pictures. So you wouldn't want that on necessarily with your nighttime garments. They do come with sleeves that are right in the packaging to cover the Velcro. Just to avoid any snagging, although I really don't see issues with the snagging with these garments. I have patients with lipedema, if they work at home and they can tolerate wearing these in the evening when they're working, to go ahead and do that. It's not just for when you sleep, but just more for when you're not out and about. On the right hand side, this shows a full leg. So I have the calf piece and then that thigh piece, which also covers the knee. It's nice to have this option of mix and matching, especially for that type 2 lipedema, where there's such a drastic difference in the size of the thigh compared to the size of the calf. And then this is a picture of the custom Tribute Night. So the patient is wearing the sleeve over it on the left and just has it on the right. This is ideal, of course, because it's custom fit to the patient. And, L&R has that 45-day fit guarantee. If something's not right, they'll fix it. And as always in the history of the Tribute Night garments, within that first year, if you really reduce, they will do free alterations for your patient. So it's really a valuable item that, has a lot of quality and is going to last a long time and do a lot of good for our patients, especially with that fibrosis. As I mentioned, that foam is so important. The L&R nighttime garments and have this irregular chipped foam in them. So this varying densities is really important, just as therapists, as we've always made our chip bags, with different kinds of foam and different shapes. You're going to have more contact points when you have these irregular cut pieces. And I was discussing this with someone the other day and saying it's kind of like a meat tenderizer. If it only had 4 points on it and you laid it on a steak, your steak's, not going to get as tender as if you had, a meat tenderizer with 100 points on it. So you really want those different contact points. This irregular shape here really helps with conforming over the elbow areas, the knee areas, and improves just the density. There's going to be less air when those pieces can kind of fit in. So I do find that those are really great long-lasting garments. All right, so we are getting close here to finishing up the material. Exercise, I won't go into a ton, but just be, aware that they're going to be limited by pain. And they've been told their whole life to exercise and lose weight, and they find it just exasperates things. Now you really have to sell them on the fact that as we're moving these toxins and lactic acid out of the legs and they're feeling better, that they're going to be able to tolerate exercise better. And, hopefully we can work on that joint alignment that was causing arthritis and pain. So really talking them through this process and not just handing them an exercise program. All right, core strength is always important. You do want to do more low impact type exercises to protect those hypermobile joints. So I don't suggest running. In fact, if someone is a runner, I try to find some other ways we could maybe get the cardio as well as the strengthening in. Swimming's a great option. And then just giving specific attention to the VMO, the hip extensors, the glute med, and making sure we're working on that IT band if it's tight with either foam roller or stretching. And then just, addressing the overpronation issue or the flat feet issue. If you need to send them for specialized orthotics or get something off the shelf. Okay, and as always with CDT, skincare is important. You do want to keep the skin moisturized, fragrance-free, dye-free. Regular washing also important, especially between the toes and in the folds. We just want to reduce any risk of infection or skin breakdown. So care with nail care, keeping those toenails trimmed. Usually the feet aren't involved, but you can still scratch yourself. And avoiding injuries, of course. And then that education piece. This is a huge part of what we do as healthcare providers, and probably, in my opinion, the most important piece. We can do all the techniques, but if we don't teach a patient that self-care, they're not going to get the desired results. Now, this is especially true in lipedema, where it is a longer duration of seeing results. And with lymphedema and lipedema, it's always a lifelong management. So really important. We want to teach them those precautions, to avoid hot packs and hot tubs, avoid injuries, teach them the signs of infection, red, warm, pain, may or may not have a fever. Teach them the self-MLD, self-manual lymphatic drainage, and or work with them to get an advanced vasopneumatic pump. Then also work with them compression use and care, as well as self-wrapping if that's indicated, reminding them they have to upgrade their garments, usually every 6 months or so. And then if there's any specialized things like the kinesiotaping, that was helpful, teaching them how to do that to themselves. And then of course that home program, their skincare and diet. So I've mentioned most of these, but they're just the big differences between lymphedema and lipedema treatment. We usually have the delayed diagnosis with lipedema. With lymphedema, you get one limb that starts to swell. A doctor's usually going to say, let's check for blood clot, and then it must be lymphedema. With lipedema, a lot of these patients go through lose weight. It's just fat. We don't have anything that can help you. So just keep that in mind. The lack of resources and education, that longer duration of care and how important it is to be consistent. The frequency, adjust that as tolerated. The pain that comes with all of these techniques. The difficulty they may have with compression. Don't give up. When I started treating this, I had, therapists would often say, oh, you can't put patients in compression if they have lipedema. And I found that to just absolutely not be true. You just have to work with them slowly. Okay, the wrapping can still be beneficial and that lifelong management. So I debated taking this picture out down into the last minute. This is a photo of a patient of mine that's had 4 treatments. And I just want to see, it's pretty hard to see here, but this fat pad is already decreasing. This fat pad is already decreasing. We're having reduction already throughout the calf and into the ankles. And, she's noticing and having improved knee pain. So in 4 visits, you can start to see some improvements, even though it does take longer to really break down the fibrotic areas. This is a surgical patient that had liposuction. So these are pre and post CDT. The one on the left is when she started treatment with me. After 10 visits, she'd lost over 2 liters of fluid. And then now we're at 15 or 16 visits. You can see definitely more. Oops, let me pull my laser pointer up here again. You can see, more definition there at the ankles and just through the calves and those gastroc muscles starting to show a little bit more. We're seeing decreasing now here through the thigh, and even up in here, there's some concavity happening now. Even a little more definition here around the knee. So even though she had the liposuction, the CDT is very important and helpful when recovering from that treatment. Hair growth, I mentioned this in the first presentation that a lot of patients with lipedema don't have any hair. So this was actually that same patient that had liposuction, and she started getting a lot of ingrown hairs and then actual hairs growing. And, so we had this big discussion. She said she's never in her whole life had hair on her legs, and now she does. And although she's not thrilled about shaving, it is such a good sign of health that your skin now can support growing hair, that the nutrients and the oxygen from the arterioles can actually reach up to these follicles and support life. So I thought that was just cool to show. Okay, and then nutrition recommendations. I am not the expert on nutrition by any means. We do give out some handouts to our patients. If you are interested in this, I really recommend the nutrition guide for lymphedema and lipedema. You can even buy it on Amazon and download it. It's a great book. It's very thorough. But generally, lots of fruits and vegetables. They recommend fermented foods, but really limiting your meat and sodium, and then avoiding sugars, gluten, modified fats, and dairy. There are a whole list of supplements they recommend. You hear about selenium a lot, as well as the butcher's broom, turmeric. So, that's outside of the scope of today to talk about all that. And then research. They just came out with the standard of care for treatment of lipedema in North America, which was great to see an article like this that kind of sets up our standards. They graded as 1+ or 2+, whether they recommended it strongly or weakly, and then the quality of evidence as either A, high, B, moderate, or C, low. Well, what really bothered me is although there was really strong recommendations for CDT and surgical intervention, the amount of evidence and research was low. So this just shows we know what things help our patients, that we really need to start trying to do some case studies and more research on the techniques that we see help, so that we can turn that C into an A. The only thing that I mentioned today that really got the A+ rating was the pneumatic compression devices. And this is because they do so much research and they really look into this. So mentorship, super important. We know that in our formal education at the university level, we don't get much training on lipedema. Even our lymphatic certification courses, there's not a lot on lipedema. And there's not that many specialized courses. So you have to learn from the literature. You have to learn from hands-on in the clinic. And I really recommend seeking out mentorship. And once you feel like you've really got a good handle on successful treatments, gifting that mentorship. All right, so the key points here: manual lymphatic drainage, deep techniques, very important. Really customize your compression. Exercise program and kind of holding their hands through that to start out with. That education on self-care techniques, taking care of their skin, the importance of really trying to get more research done in this area, and the gift of mentorship. All right, so I'll just set this here for a second. Additional resources, if we don't get through all the questions, you can feel free to reach out. My nonprofit website is lymphedema.nm, is in newmexico.com, or you can also find it by typing in everythinglymphedema.com. The lipedema.org is great. They have a registry they're trying to build. So if you know patients that have lipedema that can register, that would be awesome. Lipedema Project is another great resource, and curelipedema.org. Cure Lipedema also has a lot of sites and references listed on their webpage. So it's a great place to just find consolidated resources. Okay. All right, so thank you guys so much for listening. That was, again, a lot of information. I really want to thank Jeanette and the National Lymphatic Network for sponsoring this and bringing this information to a larger crowd. And of course, Lindsay and LNR for all the great things they do for therapists and patients and their quality products. And yeah, always being open to new things and really listening to us therapists. So thank you guys. If you keep putting your questions in the Q&A box, and we'll start taking those.
Thank you so much. That was a wonderful presentation. I think that if we take all the questions, we might be pulling an all-nighter. But I wanted to say that I definitely learned something new from you. I have never heard of the witch's hat before. And I think that's a brilliant technique, and I will definitely be, trying that. Usually, when I think of the scar tissue management, like I would use like a more a tape, a medical tape where there isn't as much elasticity, but obviously that's only as good as while you're using it. So obviously the elastic taping, it's meant to last for several days and it's meant to be durable. So I think that's just brilliant. And because we are the National Lymphedema Network, I do feel the need to just clarify one thing in terms of lymphedema diagnosis. It's not exactly as clear cut as you had said. It's a little bit more in line with lipedema diagnosis, where patients often get the runaround where, doctors attribute it to post-surgical swelling. They probably banged their limb, venous insufficiency, and the whole host of differential diagnoses. And so I just felt the need to advocate for our patients.
No, I mean, they definitely can have struggles too. I just don't see it to the extreme nature as lipedema, but absolutely. And I'm passionate about both, obviously. And I want to educate every provider on all of the conditions. So yes, thank you for adding that.
Indeed. Okay, well, I'm going to give it over to Lindsay, who is going to basically manage all the cues.
So we've got about 40 questions in here today. So we're going to try to power through these. So what would be a typical frequency and duration for treatment of a lipedema patient?
Totally, you can't answer that, right? I mean, depends on stage 1, stage 2, stage 3. Typical, we generally see twice a week. Could be anywhere from, I mean, as long as we can, and they're still making progress, I guess, until they plateau, several months. And then we'll see them again in a year, say, go keep working on this, and then come back when we're down to the next level of fibrosis. And then we'll adjust some things. So, yeah.
Awesome, thank you. How are you measuring the loss of liters of fluid?
We do the volumetric measurements that I was taught through Academy of Lymphatic Studies. So we do every 4 centimeters all the way up the limbs. And then we use our volume based on the volume of a cone. We use our program in our documentation. So it's very objective. We start at the distal end of the lateral malleolus and the lower extremities, and then the ulnar styloid at the upper extremities. Yes.
Awesome. Would you ever just use a tribute wrap instead of bandages?
Yes, I don't use bandages on every patient. Bandages, it's more if there's more fluid. I would say tribute more if it's more fibrosis, and also tolerance level, but absolutely.
So then to go with the tolerance, do you have them keep the bandages on as long as they're tolerated between sessions?
Yes, usually up to 72 hours. If they stay in place, they can tolerate them. There's no slipping, pinching, anything like that. Yep.
I think you already answered this, but how frequently do your patients come in for bandaging?
Yeah, usually twice a week.
Looks like you used 4 layers of short stretch. That seems like a lot of compression. Do you start with this many bandages initially or work your way up?
It kind of depends on the size. I think that was an appropriate amount for that size of leg. It was quite a big limb. I could have started with 3, but I would start with no less than 3. It totally depends on the size and the tolerance. So really going with your experience.
Can you go over the scar taping again? Is it just 2 pieces?
For the witch's hat, you basically would take a strip and then pinch the middle of that together to make a tab. Then you would take another strip and make a perfect cross or X, so like this, and pinch it together in the middle. So you're making a little tab. Then you take that rectangular piece, cut a hole out of the middle, and lay it on top of the tab. Okay.
With prolonged treatment, how do you determine therapy frequency for insurance purpose?
Whoops, sorry, my background just fell down. So with prolonged treatment, I mean, obviously our treatments are often indicated by insurance companies, regulated by them and what we can and cannot do. So we have to work around that. We also have to follow our own code of ethics. Are we still making progress? Are we improving their pain, function, mobility, volume, all of those things? So, that's just kind of one of those things you have to keep working with as well. You have to look at all factors.
So you had said your MLD was a little fast for what you probably would have been doing. Was your MFR a little fast too, or do you typically just work that fast on them?
I don't think my manual fascial release was fast in the videos. The skin rolling I do pretty quickly. I think I jump between techniques certainly faster than I would on a real patient. And I'd be doing MLD between each technique. And even between a thumb push, I do some MLD and then maybe do another one. So yeah, that's a good question. The eye stim though, you do pretty quickly because it's so painful. So when I took that course, they actually said if it's too painful for your patient, just do it faster. So like anyone can handle a severe amount of pain for 2 or 3 seconds. So the eye stim is pretty quick.
What about quadriva's therapy?
I'm not familiar with that.
All right. How do you feel about a mini trampoline?
I love rebounding, just showing a patient not to jump, that their feet stay planted and that they bounce. But, I think you can feel the drainage happening when you do it. So having them do it, the right way and putting on some music, it's a great way to get your lymphatic system moving in between, MLD sessions. Yeah, absolutely.
Are you ordering patients' garments, having them order them online, or do you have a luxury of having a vendor or fitter, brick and mortar type place nearby who can measure for them?
Well, all of the above. You would kind of go by insurance too. If it's an easy fit and their insurance won't cover it, we'll help them order online. If it's a more complex fit and they have insurance coverage, we have the luxury of having Active Life, a local orthotics and prosthetics company, come into our clinic every other week and set up a shop where they measure, fit, really spend the time and give that customer service to our patients, which is awesome. They're about an hour away in Albuquerque, so they've done that really nice, generous gift to us to come here. And now, very soon, they're going to open up a brick and mortar in Santa Fe. So we're excited to have that great skill for our patients. But yeah, we do all of the above.
Someone had asked, what do you do for your patients that cannot afford compression pieces? Maybe if you have any creative solutions or ideas that you typically use?
Yeah, that's such a tough one. I mean, I think like most therapists, we keep things that don't fit other people and we try to gift as much as possible. Occasionally there'll be some type of grant or we can get the foundation to help. But it can be really tough and a real struggle. I try to talk about it way up front. I had one patient who had to really save money, and then she came in one day and said, you know what, I got birthday money so I can buy my compression. So it is hard, but I think we do everything we can, right? We save and donate and sometimes buy things out of our own pocket. So yeah, I wish I had some great options there too, but I often will alter things. I'll add elastic to pieces that are needed or take in a hem. We use tubing grips sometimes if that's all they can do and double it up at the distal ends. And, so yeah, anything and everything we can.
Do you suggest using a vibration plate at any point in the process?
I don't necessarily, but I think there's pretty good research for that too. If we had a place in town that had one, I'd probably say, yeah, if you can afford that and it's helpful for you, go.
Okay, and so I think that kind of goes with, would you use the vibration plate for home program use?
Sure, yeah. Yep, I think very similar to a rebounder, but it's the whole body. So yeah, I'm totally a fan of those.
Aside from BioFlex, what other over-the-counter brands do you find helpful?
Well, I mean, I kind of dip into all of the major companies. Certainly LNR has been my favorite, especially for nighttime, and their Velcro compression garments are really useful. I do like the ComproFlex shorts from Sigvaris. We use those a lot. If patients can't tolerate heavy compression right away, we use a lot of Solidea, Capris. CS Dallas, an Italian company, has some good leggings that are easier to put on for patients. But we use everything. We use Medijobes to do so, BSN, everything if the thing is right? But we do tend to have our favorites. So Swell spots nighttime, especially going with LNR. Okay.
I think this might have been asked the other day, so I'm not sure we're going to have the answer for this one, but do you have an ICD-10 code for lipedema?
You know, I think they just came out with one because it comes up automatically in Epic now in our documentation system. So we do choose the lipedema coding, but unfortunately, I can't tell you exactly what that is. I mean, lipedema is I89.0, and on the back end, maybe it's still the same. So I'm sorry, I don't have that exact answer and probably should.
When you do your volumetric measurements, you said in the UE base is at ulnar styloid. Will that mean you stay on the medial side to measure all the way up? And with the LE, you said lateral malleolus.
Yes.
So measure all the way up the lateral side of the limb? Or does that matter as long as your 0 starts there?
Yes, and I actually misspoke. We use the radial styloid in the upper extremity. I had to actually lay my arm out like, oh yeah, it's the radial one. So it's that distal end of the radial styloid. So right there, you know, getting right there. And yes, we go up that side of the arm then. On the lower extremities, yeah, we stay on the lateral edge, starting at that distal end of the lateral malleolus. Yeah, did that answer it all?
We've answered 36 questions and there are 34, so I'm not sure we are going to get to everything. I think that this means that there could be room for more lipedema webinars in the future. Can you comment on lipoma surgical removal?
Only very briefly. I've certainly had patients have lipomas removed if they're bothersome or they're in a place that's real inconvenient. You know, I think that should be the guideline. You're going to get some scar tissue with any kind of removal or surgery too, so you have to weigh that. I definitely don't recommend that patients just go get all their lipomas removed surgically, only if they're bothering.
How do pumps help with pure lipedema? I thought pumps help only with lymphatic flow, but not adipose in lipedema.
Well, lipedema always has a portion of microvascular leakage and lymphatic leakage. So there's always that component that's building up with the toxins and with that fluid. So that's where it can come in useful. I think it's more important as those stages progress. Yeah.
All right. Medicare and most of the bigger insurances require a failed attempt of a basic pump before approving an advanced pump. Any tricks to bypass this requirement?
No, unfortunately. The only thing that I can tell you is if there is any component of lymphedema there that it's starting to get into the feet, make sure you document that. I follow Dr. Herbst's recommendation that we don't say lymphedema anymore, that we diagnose them separately in combination. So you can say type 3 lipedema stage 2 of the bilateral lower extremities with left lower extremity type 1 or stage 1 lymphedema. So even if it's like, well, my left foot is swelling now, and you can show the left foot is bigger, if you can document that, that's going to help you get the pump. Then that failure in the trunk, I mean, you do have to show that with conservative treatments, MLD, compression, with all of that, that they still have either significant edema or worsening edema. The other trick with lipedema can be one of those severity terms. Sometimes patients don't have the papillomatosis or the lymphuria or the hyperpigmentation. And in those cases, or hyperkeratosis, those cases, it's just much more challenging to get the pumps, unfortunately.
What techniques do you use to help discern between areas of fat and areas of fluid?
I think that's all on our palpation skills. So when you're doing MLD and you can feel things soften and you can feel that fluid move, you don't feel that when you're working on adipose tissue. So it's kind of seeing what you feel, right? And then fat is soft, fibrosis is hard. So there too, finding those hard areas, and like dough, you're working out the lumps in the dough.
What objective measures do you use to determine treatment required and treatment outcomes?
We use our volume measurements, of course, range of motion at the ankle and knee, strength, pain, if indicated, functional mobility, and then also the lymphedema life impact scale we do use as a functional tool, which is not totally geared towards lipedema, but it's better than most of the functional tools out there as far as limb heaviness, skin tightness, skin texture. It also talks about your hobbies, your job, your home life, and your emotional side of this, how it gets you down, affects your intimacy, those type of things. That's a good tool.
All right, so I'm going to ask you 2 questions at the same time.
Oh, wow.
So that you can answer them. So do you know what brands of cups you use? And how can you use cupping when there is weakness in capillaries, which causes easy bruising and lipedema?
That's a good question. I don't know offhand the brand of the cups that I use, but I was recommended years ago to get the really good brands used by massage therapists, not to buy the cheapies on Amazon. And that is a true statement because the cheapies on Amazon break really easily and don't really have a good supply of oxygen. So they don't hold very well. Usually when I do cupping, I am not doing the aggressive cupping you've all seen on like TV and stuff where it leaves huge bruises everywhere. We are doing a drag with it, or we're doing just a maybe 5 or 10-second hold with some wiggling. It is not our desire or indication to actually have it bruise, and we don't want it to bruise. So we don't take it to that level. Great question. Thank you for clarifying that.
What about lasers?
We don't use lasers in our clinic. I don't have a lot of experience in those, so I can't really speak to that.
Is the LymphoPress the only pump approved for billing for lipedema? Have you heard somewhere?
No, I have not heard that at all. We tend to actually use the FlexiTouch just because of the amount of research it has. They've got case studies with 800 patients in JAMA. And I also like the way it really starts in the trunk. And again, we don't really get it approved unless there is that component of lymphedema on some level. And I have not heard the opposite of that with the LymphoPress. I think it's the same criteria. Yeah, LymphoPress is also a good tool though. It is a little easier to clean if there's some skin issues or for lymphedema. And there can be some donning advantages to that also.
So we had a comment, LNR wraps, that they're using LNR wraps a lot instead of short stretch, and the patients can tolerate and perform application on their own. So they frequently use those short stretch foot and calf and ankle calf wraps. So similar to you.
Oh, cool.
Do you recommend Solidea garments?
Yes, we use those. They can be a lighter compression, but work really well with some knee highs.
How do you know when they reach phase 2?
When they can tolerate it, when we've kind of plateaued on reduction and volume decreases, and we're ready to just maintain.
All right. Do your patients comment about feeling sensitive or mild tenderness on their legs after CDT treatment?
Yes, absolutely. During and after.
Do you have experience with PhysioTouch, LymphoTouch for fibrosis?
I don't. I have some colleagues that use that PhysioTouch, which I think is great, but more for the manual lymphatic drainage, to stimulate that. I don't know about the fibrosis part of that. I'm a big component of the hands because you have so much sensory input from your hands, and they can really mold. A machine can't really contour around all the parts of the body. So, I say when you can use your hands, always use your hands. And I've heard that in relation to cooking also. So it makes sense. Yes.
Someone had shared, I highly recommend underwater treadmills, especially if the water level is high enough.
That's a great recommendation.
Speaking about trampolines, would you recommend a vibrating machine to stand on?
Yes.
How do you measure the legs without the tape sliding because of the cone shape? I have a tough time keeping the tape in the same spot for before and after measurements.
Yeah, I mean, that can be challenging, but you really have to just keep it in that straight line. It can slip, but if you can, we do our measurements laying down, so it's stabilized under their leg. I always tell them, don't help, don't lift. I want your muscles to be contracting and really just kind of making sure that it's straight from front to back and getting that measurement quickly and then moving on. It's hard.
During treatment, are the patients keeping their compression bandaging on all day and night?
Yes, if they can tolerate it, absolutely.
Do many of your patients go to surgeons for assessment?
Not many, but some. I don't know that I could give a percentage on that, but a pretty low percentage because they know it's going to be out-of-pocket pay. I have someone right now who just went and saw a physician in California The estimate was $45,000 for liposuction. So it's not a lot of patients.
When you apply the fan kinesiotape, picture of sending fluid to medial knee, do you have any stretch on the tape?
Very little with the lymphatic drainage tape. It should be more just paper off, where you roll the paper off as you're laying down the tape. And then the anchor is just placed there at the medial knee. Great question. And you'll see just a little kind of like lift to the skin.
Would you typically do these techniques, S-wave, the thumb press, that quickly, or try to hold to get the fascia to stretch more gently? I guess, how aggressive is that speed for your patient?
Yeah. As I mentioned earlier, I would do more one, and especially the S-wave, do a longer hold. And then I always do some drainage in between. So I was kind of more just like, I'm going to show you all three things pretty quickly. So yeah, definitely would slow that down.
Could lipedema stop at stage 1, or does it always have to progress?
I don't think it always has to progress. There's patients that are much older that kind of stay in that stage 1. I don't think they really know why that happens or what differentiates someone progressing further. But as I mentioned on Tuesday, I always tell my patients that now you have the answers and the tools to know how to stop this progression. So not to worry about those scary stages you see online.
What do you recommend to foster independence and self-care for your patients? It's something that this particular person struggles with their patients, and they find themselves doing MLD for long periods of time.
For the patients instead of the patients doing it independently?
For them, or helping with their caregivers, so anything that you do to help motivate them for self-care.
Right. Oh, that's super hard. I mean, it really comes from the person. I think giving them help and reducing their pain, all of that can be really helpful. But it does come from the person, and that's something I'm not the best at, is really cutting someone off when I know that I'm helping them, but they're not quite doing all that stuff at home that they should be. And we really have to be strict about that and say, if you're not going to do it at home, then we need to quit treatment. So it's a tough thing. My mentor used to tell me, though, that I can't care more than they do. So I think of that sometimes, like, okay, they have to want this and care. It's not my body. So.
Yeah. Where can we get a longer tape measure, especially measuring the H on the pantyhose or shorter garments?
Great question. I don't know. I wish I had one too. I've often had to put 2 tape measures end to end or make a mark and then go again. So maybe the L&R marketing team can make super long ones to give to all CLTs at their conferences and showings.
Yeah, you'd be surprised. Tape measures are on back order due to COVID. And it is an interesting world, the ways that things get impacted.
Wow. Crazy.
Mm-hmm. How do you explain to your patients if they experience tenderness and skin sensitivities after CDT treatment?
I just talk about all the toxins that have been built up for so long, and that we're really moving this, and your body's really busy, the lymph system, your organs processing, and that things are going to improve with time. Most of them have already had this happening. Their kids lean against them with their elbow when they're yelping for pain. So I think just showing them the anatomy and physiology. I've got big posters in my room so that they really understand what's happening.
Yeah. Can I ask if you share a template of eval? So I don't know if you know maybe a specific organization that has a template for eval or daily notes or things like that that's out there.
I don't, and I can't share ours. Ours is, through Epic, which is a huge national documentation system. I really don't, but it's not that hard to really build one out yourself, to just really look at, severity terms and primary, secondary, quadrants affected, things like that. Have the volumes in there. Yeah, sorry, I don't have a better resource for that.
All right. Someone here had said that a tailor tape measures are significantly longer, so maybe a good idea.
Oh, okay. Are they in centimeters? We'll have to find some.
Someone had commented, there's a new tool that works like IASTM without the pain called the fascial abrasion technique tool. I've been using it on my lymphedema patients and it has been amazing. Thank you for sharing, Katie. Let's see. I think you answered this one. How do pumps help with pure lipedema? Per my understanding, yep, I think we answered that one already. Someone had shared, no compression garments tend to fit me. Just a quick answer that I think that custom is definitely the way to go for something like that if you do have those situations. I know specifically with nighttime garments, our tribute night, we have done, every shape, size, configuration imaginable. Every time I walk through the back, there's always new designs. So it could be something you could check out for nighttime care. And I know there's many daytime custom solutions as well.
Absolutely. And I might add mix matching too. Maybe if it's a big size difference between the upper and the lower, something else you can try. Knee highs with a capri or something.
So in your experience, Deana, do you find that most of your patients require custom-made compression garments that have
No.
lipedema?
No, usually not. You can find, knowing the different products and again, that mix and match kind of thing. We rarely do custom anymore unless it's a nighttime.
Someone had said, I learned to self-wrap my lymphedema arm after the first 3 weeks. I did not use the foam padding. It was much easier to apply the bandages and get the right tension. That is great to hear. Thank you for sharing. So do patients have to avoid hot tubs, dry or wet saunas?
I definitely say limit if you've got pretty severe lipedema, and especially if there's any lymphedema component, I wouldn't do either of those just because the temperature can be so great. A therapeutic pool, a mildly warm pool, a shower, a bath, those are okay.
If you have liposuction, can lipedema return?
Yes. I believe that's in the literature a lot, and I've seen that in my own practice, unfortunately.
Me and my lymphedema colleagues that are treating lymphedema patients and lipedema patients have cases in the medical complex population in LTAC. We show a lot of improvement with reduction of swelling and limb girth volume. Have you heard from your patients if they complain of tenderness or sensitivity on their legs after their legs get smaller? Also, I would like to ask if you can share the template of the notes, and unfortunately, she is not able to share those. This was, I think, asked a little bit earlier actually than that last one. We're kind of working our way up.
Yes. And I think some of that with the reduction is now those fibrotic areas and those nodules are more palpable and more superficial. So they're feeling some of that stuff as we unlayer. So I talk to my patients a lot about that too. It's, we're unlayering the onion. This is the next layer we got to work on now.
So just an FYI, this person had shared that if you have a lipedema patient that only has a basic vaso pump and does not qualify for an advanced decreasing the pressure 25 millimeters of mercury and teaching them to do diaphragm breathing and self-MLD proximally works well.
Yes, that's a great addition with the basic pump. I agree. Yep. You always want to prep that trunk if it's not being treated by the pump itself.
So this, I think, is from a patient they had shared, and you may have to talk to your medical professional. I would definitely recommend removing the compression in this situation and going to see your doctor. But they had said that often after wearing some of their circular flat knit compression garments, they find that they bruise on the front of their leg, and we're wondering why. But I don't think we can quite answer that during this talk, and you'll have to see your medical professional. And then we have just a few more. We've gone through 78 questions. Thank you guys, and thank you, Deana. We have been firing these off. So I know one last one was regarding can you comment on lymphedema in the breast area specifically? A lot of people have the arm, and so this patient is sharing that they do find that they're just getting in the breast. And something that I might consider is I know that Linda Rorty, I believe, just did a presentation with the NLN recently. So if you are a member of the NLN, Jeanette, feel free to jump in if you have any feedback here. But I believe if you're a member of the NLN, you're able to attend that if you are registered for the conference. I'm not sure if it's therapist only.
Yeah, I think with the breast lymphedema, we're sparing the breast a lot more now and doing lumpectomies versus mastectomies. So we're doing radiation to the full breast that's still there. So I see a lot more lymphedema of just the breast than I did a decade ago, which is good because we're taking out fewer lymph nodes and we're sparing the breast tissue itself. But you absolutely can get, it's very common to get lymphedema of just the breast or trunk and can be treated successfully.
Lindsay, what portion was in question? If you're an LN, you can attend what part?
So I was wondering, I believe there was just recently a webinar on breast lymphedema specifically. So I didn't know if that was recorded or anything, because I know that they had shared a few comments on any questions on that.
Oh yes, that was recorded, and it should have. Forgive me. The editing takes a little while, and the uploading takes a while. I will make sure that it is fully uploaded by the end of this evening. So yes, but it is available.
Awesome. So do you use or have you heard of the complexity scoring and upper extremity lymphedema scale?
For upper extremity lymphedema, we don't use the complexity scale in our clinic. We do the evaluation complexities required by Medicare, but no, we don't.
All right, I think we got to every question, and look at, we have 121 participants still on. Thank you so much, Deana, for this extra time this evening, this extra 30 minutes. We can't thank you enough for your great 2 days of lectures, as well as answering all of these questions.
Thank you to you and Jeanette for staying on as well, and all the participants. Yes, I wish you all the best and happy treating lipedema.
Thank you. But before we say our final thank yous, allow me just to do diligence and read our disclaimer. The National Lymphedema Network aims to simply connect patients and healthcare professionals to information they may find useful when exploring treatment options, educational opportunities, and current information related to lymphedema and other related conditions. The views and opinions in this webinar, which are those of the authors alone, do not necessarily reflect the official policy or position of the National Lymphedema Network. All services and products that were mentioned do not represent an endorsement from the National Lymphedema Network. The information that is provided solely for general education and informational purposes. Use of the advice and information contained herein is at your own sole choice and risk. You should not rely on this information as a substitute for, nor does it replace professional medical advice, diagnosis, or treatment. Always consult your physician or healthcare provider before beginning any nutrition, exercise program, or treatment intervention. If you choose to use this information without prior consent of your physician, you are agreeing to accept full responsibility of your decisions and agree to hold harmless the National Lymphedema Network. With that, we would like to thank Deana one more time for an amazing webinars, very, very informative, very comprehensive. Thank you so much. Lindsay, thank you so much for your sponsorship. Excuse me, please, sponsorship support. And thank you to each and every single one of you for your time and attention. We hope you enjoyed these webinars and we wish you good night.